Welcome to Hello Therapy, a podcast to help you take charge of your mental health through evidence-based psychological tips and tools straight from the therapy room so that you can live life better. If you experience OCD, should you be considered neurodivergent? This is a really hot topic in the OCD space right now, with many differing opinions, so it can be difficult to get a straight answer. Today, I am joined by Dr. Emma Offord, a returning guest and a clinical psychologist specialising in neurodivergence and OCD. Emma is the founder of Divergent Life, a neuroaffirming assessment, therapy, and coaching service. Our conversation touches on how OCD overlaps with autism and ADHD. We talk about the importance of considering how our neurobiological wiring and sensory sensitivities can shape the OCD and neurodivergent experience. And we discuss what all of this means for the treatment of OCD. I got a lot out of this conversation, and I'm sure you will too. So let's dive in. So welcome back, Emma. This is your second time here, and I'm really excited about our chat today. We did an episode on navigating neurodivergence, didn't we? I think that was episode 28 a few episodes ago. So thank you for coming back.
Well, hi, Liz, and thanks for having me back. It's really good to see you again. And
Yeah.
I am really excited to talk about what we've got planned today. I think it's
Yeah.
going to be interesting.
It will be. For those listeners who don't know you yet, do you want to give us an introduction?
My name is Emma Offord, and I'm a clinical psychologist. And I currently work privately, running a service called Divergent Life that is a neuroaffirming service. And it's been designed to really honour and work with many different individuals who identify or are diagnosed as neurodivergent and really bring neuroaffirming assessment and therapies and coaching to them that supports their needs and preferences.
Great. So I wanted to get you back on to talk about a subject really close to my heart, which is OCD or obsessive compulsive disorder, and how that intersects with neurodivergence. And I'm bringing you on because I'm having an increasing number of conversations about this in my therapy room with clients. And I know that there's some debate around whether people diagnosed with OCD are in fact neurodivergent. So I'd really like to start with what is your take on that?
So I have my own take on that, which I would say aligns with the neurodiversity paradigm or neurodiversity movement that believes and honors that all brains are different, brains and bodies are different. And so, trying to understand this diversity of experience and diversity of development and work more broadly with the acceptance that all of us are different. So that particular perspective would include OCD because our understanding or our developing understanding of it, of people who experience OCD or OCD is that their brains might operate in a particular way or their bodies might operate in a particular way. Their behaviors might show up in a certain way that lean towards this understanding of OCD. So that's the kind of difference or diversity that somebody identifying as OCD might fit. Yeah, so I think for me, in the way that I practice, OCD is considered neurodivergent, and that is slightly different from neurodiversity, although it's part of it. Neurodivergence is a way of describing how people might diverge from what is considered the predominant neurotype. So the kind of normal, and those are not my words, but the normal way of living and socializing and processing information and being in this world. So yes, they're part of the diverse nature of all of us, OCD individuals, but are perhaps considered neurodivergent as a different way of explaining their experience from the predominant neurotype.
I think that's where I struggle, because if we're thinking in terms of neurotypes,
Mhm.
and the assumption there being that, let's say, if you are autistic or you're an ADHD, that's something that you are. It's the way that your brain is wired, and therefore something that you're
Mhm.
that's the way that you are born, right? That's your
Yeah,
neurotype. So that's where I get a bit confused around the idea of OCD. OCD being the sort of, I guess, traditional conceptualizations of OCD is it's a mental
yeah,
health condition or problem, and not necessarily something that you're born with, but something that can develop over time or in adulthood or in teenagehood, sometimes in children. And therefore, it's not a sort of permanent fixture in
yeah.
your life, like it's something that you can recover from. So what would you say to that?
Yeah, so it's poorly understood. I think
Yeah.
there isn't a straightforward answer here. But yes, some neurodivergent neurotypes are considered or put in the category of neurodevelopmental. So
Yeah.
an idea that you are kind of born with a neurotype and it's a trait rather than a state. And I
Yeah.
guess how sometimes OCD is seen is more of a state that it shows up and then it can be worked with or
Mm.
treated and then it goes away and then it might come up again or it might not, and it has
Yeah.
these cycles or episodes, so it's not seen so much as this static continuous experience or neurotype in that way.
Mm.
However, there's a lot of overlap with what's described as being OCD and autistic and ADHD and also other neurodivergent descriptions. And from my experience of working with people, you can absolutely see traits of their neurobiology that almost not predispose them to head towards a more OCD like pattern of behaving and thinking and feeling, but maybe those aspects interacting with the environment that they're in bring out these behaviors that we describe as OCD. So I'll give you an example to illustrate that. So somebody might have sensory sensitivity as part of their neurobiological wiring. So they're born very sensory sensitive to certain things like noises or to smells. And when they're at home growing up and they're not exposed to too many of those smells or those noises, then they're pretty regulated. They're quite calm. They're not in distress. They're not in any kind of anxious or distressed place that feels overwhelming. But then that individual might go on holiday to a new place that's really stimulating, or a city or a school, and they're regularly introduced to noises and smells that dysregulate them.
Mhm.
And then in response to that, they might develop rituals or compulsions or avoidant type behaviors, which is typical of how we describe OCD
Yeah.
and some OCD responses, to try to regulate and work with that constant triggering of distress.
Mhm.
So without that sensory sensitivity or being exposed to it, then this emerging picture of OCD wouldn't be present.
Mhm.
So there are these underlying traits, these underlying neurobiological components to that person's wiring that contribute to why they might start to perform rituals or compulsions and avoidance of certain things.
Just to let you know, if you struggle with anxiety or OCD, I want to personally invite you to check out my YouTube channel. I have a growing library of videos that offer practical step-by-step strategies to help you cope with all types of anxiety and OCD, leaving you feeling more empowered and confident in managing your mental health. So head over to YouTube, search Dr. Liz White, or hit the link in the show notes. And don't forget to subscribe for regular tips and tools that you can use to start feeling better today. Let's get back to the episode. And so let's get into specifics, because I think it would be helpful to think about, as you say, like the co-occurrence of, let's take autism first, with OCD. And I appreciate that every one of us is very different and there's lots of nuance. But in terms of what you have come across in your clinical work and the clients that
Yeah.
you've worked with, what have you tended to notice in terms of someone presenting with OCD who is also autistic? What might you see there?
Yeah, so again, it's there's so many different and varying
Yeah.
examples. So I certainly see it in terms of people's sensory systems. And again, not every autistic individual will be sensory sensitive to every sensory
Mm-hmm.
stimuli. So some may not have noise sensitivity or auditory sensitivity. Some
Yeah.
might, and it will be of varying degrees as well to what they can tolerate. So, what I often see is, and I'll give an example of children in school because that's what's been showing up quite a lot recently with lots of children going back to school, that these children are also diagnosed autistic, by the way, as well, that I'm going to give
Mm-hmm.
examples about. That entering back into the school environment and either the sensory demands or the relational demands or the learning demands has meant that when they've come home, their rituals have increased. So, where over the summer, all these rituals, these behaviors, not necessarily went away, but were not so intensely relied on or just so intensely present in the home. Some of these children have returned to school and then very early on in their transition back to school are needing lots of repetition, lots of ritualistic type play, or
Yeah.
they might have very ritualized routines before they go to bed or before they get up in the morning and go to school. So, trying to regulate some of that dysregulation of being in school means that, in a way, their very clever nervous system is trying to put some order back into their life or
Mm-hmm.
help them to make sense of the world in front of them when sometimes it doesn't make so much sense when they're at school, perhaps. It can be lots of hypotheses as to why that
Mm.
seems to regulate or is soothing. But yes, you might see an autistic individual in school who then their rituals increase as a result of transitioning back to school, and then they lessen perhaps in times away from school. So that's one example. Another example is, and again, it's such a vast area, but you can also think about the sensory world in terms of our interoceptive world, Liz. So the body signals that go to our brain and how sensitive they are.
Mm-hmm.
So I don't know about you, but I tend to get quite a lot of people who have the theme of health or somatic type
Yeah.
OCD themes. And maybe some are diagnosed autistic or maybe they aren't, but there it transpires in the work that we've done that they have high sensitivity to their heart rate or to their bowel movements or to
Mm.
the temperature of their body. So
Yeah.
they are very, very receptive and aware of the information that their body is sending to their brain about how their body is working in their organs. And from that, often can be
Mm-hmm.
born these themes of, am I having a heart attack? Do I need the toilet? And then keep returning to the toilet, and that becomes this compulsive behavior before bedtime. Or so that's a very kind of sensory perspective, and a lot of autistic kind of understanding is around their sensory sensitivities and sensory awareness. So that's where I think there's quite a strong link between
Mm.
OCD and autism, is this whole idea of sensory sensitivity and how triggering that is. So in that example about the body, rather than it being an intrusive thought or image generated in the brain, it's an intrusion or an intrusive sensation in your body that the brain then tries to make a story up about. What is that
Mm.
sensation? It's your heart rate too fast. What does that mean? And then it creates this
Mm.
intrusive thought, catastrophic idea about
Yeah.
what's going on there.
Mm-hmm. And linked to that, I guess where my mind went to there was the understanding of autistic rituals typically are born out of a desire for sort of predictability and that sort of need for routine,
Mhm.
whereas compulsions are more about managing an anxiety or doubt. And I can see how it then is quite difficult to tease apart because they can look the same on the surface, can't they? But
Yeah.
the function can be very different.
So yes and no, because I think that uncertainty and kind of feeling safer when things are more certain is about anxiety and fear. I often think more in terms of regulation and dysregulation and what
Okay.
takes people in outside of their window of tolerance.
Yeah.
And that can be your sensory world, that can be an intrusive thought, something that you fear. It can be change and uncertainty. So there are many things that take people into dysregulation, which is really what we're calling anxiety and fear, aren't we?
Yeah.
And they might look different. So I think some of those fears and what takes people outside of that window of tolerance into dysregulation is shared across many different neurotypes. But there might be more distinct things that are perhaps more shared by an autistic person or more shared
Mm.
by somebody who experiences OCD or
Mhm.
an ADHD. So there is overlap, but I would say that actually a lot of those behaviors and rituals, I mean, in the autistic kind of assessment, it's called restrictive and repetitive behaviors and special interests. So it's sort of being obsessed in an interest. And so you've got the obsessive
Mm.
interest kind of,
Mm.
or special interest confusion there. Like, when is it an obsession and when is it
Right.
a special interest and when is it hyper focusing? I mean,
Yeah.
if you look at their definition, they're kind of very, very similar. So that's a confusing thing, but they all exist across these three kind of descriptions: repetitive, restrictive, repetitive behaviors. That sounds quite compulsive to
Yeah.
me in some ways as well. So you also can get, variation that maybe somebody looks regulated or appears regulated, so the motivation doesn't seem only fear-based. So that could be that more ritualistic behavior of doing things on repeat, and that kind of scaffolds somebody and keeps them in that place
Mm.
of regulation rather than them trying to get out of dysregulation. It's the
Yeah.
scaffolding to kind of keep them there. So I think repetitive behaviors, compulsions, rituals are kind of a human nature that we have been sharing for centuries and centuries and doing in different ways. And some are considered more disordered than others. Some cause more harm for people than others, especially if they get very restrictive, very repetitive, very
Mm.
just intense and lock that person down. But I think it would be really interesting to actually, compare all of those and see their
Yeah.
similarities rather than looking at their differences
Right.
sometimes.
And I think the thing for me there is within the OCD experience, the thing that's quite key is obsessional doubt. So where there's doubt in an OCD experience, there's usually a compulsion of some form, whether that's a mental compulsion or an overt
Mm-hmm.
compulsion. In autistic repetitive behaviors and rituals, I'm guessing there isn't that doubt. It's a different experience. If we're talking about an autistic person who doesn't meet the criteria for OCD, for example.
Yeah. So again, it really does vary. Autistic people experience a lot of doubt that lead to
Yeah.
compulsive behaviors or rituals, but also they might be movement seekers. And so their sensory world needs kind of what we call proprioceptive feedback, or they need to be upside down, or they need their body moving. And so that
Mm.
can be very repetitive. And that might not be so driven by fear, but if they didn't do it, it would be stressful and that could lead to anxiety. So if they're in an environment where they're restricted and not able to movement seek, then the stress appears. But if they
Mm.
can, then that in itself is not driven by doubt.
Yeah.
It's something different altogether. So yeah, that I would say that sort of expression of repetitive behavior isn't necessarily doubt driven, but there will
Yeah.
be other repetitive behaviors and rituals that are all
Mm.
about doubt. Self-doubt: do I fit in? I'm different. Am I not like everybody else? All of those kind of relational comparisons and social kind of measuring themselves against other people. Can I survive this environment? There are lots and lots of doubts about being safe in the world around them, outside of
Mm.
very predictable environment. So
Yeah.
it's actually, yeah, overlapping, and there are these separate parts too that maybe, yeah, need to be thought about a lot more in order to be able to understand what's different and what's similar, and therefore what's more helpful in working with these
Yeah.
individuals and their individual needs.
And that's such a great point, isn't it? Because I think as a therapist, as a clinician working within the OCD arena, you have to have an awareness of these issues, and
Mhm.
you have to have an awareness of the nuance and be looking for those nuances rather than
Mhm.
just assuming that because someone is autistic, it means X, Y, Z, right? It has to
Yeah.
be an individualistic assessment and treatment plan.
It does. And as far as I'm aware, you wouldn't typically think about a referral to an occupational therapist to work with somebody with an experience of OCD, but that might be much more of something that you would consider as an additional referral or part of a healthcare team is to have occupational therapy, working with the body and using the body as a resource for regulation. And actually, if we understood OCD a little bit more from this neurodivergent, neurobiological perspective, that understanding we might bring into how to help somebody when they're feeling distressed by their compulsions and by their
Yeah.
obsessions. Maybe we can work with the body. Maybe the source is actually the dysregulation of the body, or the trigger is the body. And, by opening up OCD or, just other what we consider mental health disorders to this more neurobiological understanding opens the doors to other ways of working and helping people that could actually make a huge difference
Yeah.
to their experience. So, yeah, that categorizing does close the doors to certain things, I
Mm.
think, in terms of understanding what that person might need and benefit from.
Yeah, absolutely. And can we touch on ADHD as
Mhm.
well? So we talked about autism and OCD, but can you give us a sense of what the co-occurrence of OCD and ADHD might look like?
Yeah, and my answer is going to be really similar in that it's so complex, and I don't have
Yeah,
the answer. I can give this sort of
yeah,
more practice-based evidence of who kind of comes through my doors and who I work with, my own personal experience of OCD and ADHD, and where
yeah,
that might go in my practice. And this is not, sort of well researched. This is what I've witnessed and seen. I see a lot of sensory seeking behaviors. So sometimes not. Definitely not all ADHDers. Many autistic people are sensory seekers too. But sensory seeking behavior can become a regulator and become obsessional and compulsive and then dip into dysregulation. So an example can be exercise. People can be very regulated by exercise. It can be a good strategy, but they can be very, very obsessed about it, and almost if it can't happen in the routine way that it's been designed, then that can be a really distressing and devastating experience. If you miss a day and you've got this weekly plan, or it can be about food, seeking certain kinds of
mm,
food, so you can see disordered eating of a different variety as well, restricting or
mm,
kind of emotional eating, or kind of more binge eating where it's of that sensory seeking kind of way. So I kind of see, yeah, a lot of ADHD coinciding with sensory seeking that can sometimes get a bit out of hand for people. But again, then I can also name lots of autistic individuals who would also fit that kind of profile too. And it's hard to differentiate and say there's like an ADHD OCD type, and then there's an autistic
yeah.
OCD type, and then there's
Mhm.
this OCD type that has neither ADHD or OCD. It's actually just much more merged than that all over. And
Mm,
there might be some people who really stand very still and are comfortable in their autistic space and do not identify as OCD or ADHD, and likewise
yeah.
across the different neurotypes. But there are some people who have, so much going on that it benefits from bringing in all these perspectives and thinking
Mm,
from these different lenses, like how might this help this person? What might be driving that behavior? Should we look at the
yeah.
body in the sensory world? Is it more doubt based? Yeah, I think the
Mhm.
emerging, where it's more transdiagnostic,
Yeah.
could be a much more helpful space for people.
Mm. Yeah, and I think the research and the studies and the thinking isn't quite where perhaps it needs to be at this point in 2024. I don't know about you, but it feels like an emerging area of interest.
Definitely, definitely. And
Mm.
a lot of the research that I've read so far doesn't include the sensory system, which don't
No.
stop talking about that because I think I just see such a huge part of that as being, a neurotype experience. But when people are researched, they're still kind of researched from this evidence base of, a cohort of autistic individuals compared to a cohort of OCD individuals. And so that's just already messy.
Yeah.
It's not very, it's still staying with the same language. So it's not that helpful in breaking away from that and being a bit more creative about what might actually be happening for people. So we're not there in any way yet in understanding all of this.
And something that I have experienced is talking with people about, going back to ADHD, is there are certain sort of compensatory strategies that people employ when their ADHD is, in order to manage things like difficulty in planning and losing things and that kind of stuff.
Yeah.
But those behaviors, like, having to put their keys in a particular place, but it has to be in that place, and if it's not in that place, then comes the dysregulation and the anxiety. But those compensatory strategies can look like or can function as compulsions, can't they? Like, I need to do this because
Yes.
I have an anxious or obsessional doubt about what if I can't find my keys, or what if I can't get to work, or whatever. Is that something that you talk about in your work with ADHDers?
It is a lot. So sometimes it's kind of described by people as like their scaffolding, their organizational scaffolding, that they
Yeah.
almost have to be obsessed and rigid about it, or else it won't work. It can't be a
Yeah.
loose plan because things
Yeah.
go wrong when that happens. So that can cause a lot of distress. And I think what you said there about function, like OCD or compulsion, that's what a lot of rituals and compulsions, they are functional, at least to start with, and then they might end up malfunctioning for that person and causing distress elsewhere, or just becoming unsustainable for a person. But kind of a picture of perfectionism can emerge for many ADHDers and autistic individuals. And there's that link of perfectionism and OCD as well, isn't there, for some people? So it sort of organizational things, planning, just ordering stuff so to the outside world it looks very calm. But to create that level of order is so chaotic and distressing. And we would call that a masking type of behavior, because in order to fit in, which requires high levels of organization, especially for an ADHDer, you have to go to these extreme levels to function and meet those expectations. So that is a mask. That is not a person's preference or natural tendency to live in that way necessarily. So some people do have joy from organizing, and that might be a kind of link to sensory seeking and sensory enjoyment. And so that doesn't necessarily, for some people, feel quite as distressing or stressful to create and to do. Not every ADHD either is in chaos of organization. That might come really natural to them. It's one of their skills, or it's part of their sensory abilities, but the chaos might be somewhere else, like in how they purchase things. They might be impulsively buying, or something else is sort of falling apart, and not everything falls apart for an ADHD all the time. Some things are held very, very, very together, and other things, maybe they require these strategies, scaffolds, rituals, compulsions.
Yeah. And I think in my experience also, I can be working with someone who, say, has a diagnosis of ADHD, but I'm working with them around the OCD, and that experience of, well, okay, so I have this label of ADHD, but it's the OCD that's really causing me distress. And I think in people's mind, like, the two things are very separate and experienced in a separate way. But also what we were saying earlier, like, but there can also be an overlap. And again, we're coming back to, it's very, very individual. And I think the thing is that when ADHD or autism gets talked about in social media or wherever, there can be this, it's always sort of broad brush, isn't it? It's like, well, this is what ADHD is, so this is what ADHD looks like. But when you actually think about it, get into it, and clinical experience dictates that what we know is that no two ADHD individuals or ADHDers are the same. It's very individual.
Yeah, exactly that, exactly that. And I always want to, when it feels confusing, when all of this feels, and it feels confusing to all of us,
Yeah.
the professionals who are helping, the researchers, the people experiencing what feels sometimes like contradictory states, like parts that are, just not aligned to each other within us.
Mm.
Um, so, I think what I rely on is, really thinking what's useful? What do we take from all of this? We don't
Yeah.
have to stay in one box. We can take what we want actually and use that, and that's perfectly fine. It
Mm.
gets a bit more complicated when it's young people and you've got to explain to perhaps healthcare professionals or schools or your employers. But I think for you, for people as an individual, take the parts that work for you. And there's also an idea in society, I think, that we are this kind of coherent personality. And I actually think we can jump around. We are very dynamic. I can
Yeah.
be calm, then I can be, really dysregulated and just irrational and just not, very, very sort of intense, I suppose, is a better way
Mm.
to put it, rather than very calm. So I know that my state shift depending on
Yeah.
what's going on, and it happens to all of us. So these different parts that might get a label, or we might look at them
Mm.
as traits, or we might look at them as neurobiological components of our wiring and our, you know, how we're designed. We take what's useful, and we don't need
Yeah.
what isn't. Is my
Yeah.
kind of way of getting through all of this.
Mm. And I think one of the things I wanted to touch on was I have quite a lot of therapists, psychologists that listen to the podcast. And I wondered whether you had any ideas about treatment. So, someone who is helping someone with OCD, let's say, but there's neurodivergence in the background. What are the things that we need to be considering or thinking about in that scenario?
My preferred way of approaching that would be, say, if somebody has a diagnosis of autism and or asking for some help with a compulsion or whatever their OCD experience is that's become distressing,
Yeah.
I would really want to know more about their autism. I'd want to know more about what are their autistic traits, what's their autistic identity is probably a better way of putting it.
Okay.
So I would want to know about how they process information, because that really helps in how you present ideas to people and what they're more
Yeah.
susceptible to and open to and likely to take in. I'd want to know about their sensory world and how that might contribute. Also, can we use the body to regulate? Can we use sensory tools to help that person rather than more ritualistic strategies that are unhelpful? I'd want to know about what might be going wrong, where they feel unsafe in the world. Is this a response to certain situations not feeling safe, like I mentioned earlier, school or work or their own self-identity? Or they're in the health OCD theme, is it their own body that doesn't feel safe, like
Mm.
doesn't feel safe to listen or be in touch with their body? Have they had a trauma experience? Is some of this associated with trauma? So for me, it would be looking at this, what's safe and what's not safe, and how their biology might be or neurobiology is interacting to not produce OCD, but for people to have this
Yeah.
OCD experience that becomes something unmanageable that they can't cope with. So yeah, I'd want to do that, and I'd also be wanting to let go of a lot of my training that suggests, you have to have a particular treatment plan that goes like this.
Yeah.
And yes, there's a lot of evidence and it does work for a lot of people, but I'd be at the ready. If that person said, I really don't think I can do that, I would not want to be dysregulating them any further than they already are, because that's
Mm.
often part of the OCD experience is I'm trying to help my dysregulation. And it's
Mm.
kind of creating more dysregulation,
Yeah.
unfortunately.
So you're talking specifically about exposure response prevention and how that is incredibly challenging for anyone to do.
Yeah.
I think particularly in the sort of contamination, OCD or fears, where you really have to go outside your comfort zone, and that
Yeah.
experience of disgust can be dysregulating. right?
Yeah.
And you have to, or in any therapy for OCD, it's about making sure that the person has some skills in order to manage the anxiety that's going to show up for them within the exposure hierarchy. But for a neurodivergent person, it's really thinking about, actually, is this the right way to go? Like, is there a different way that we can approach this? Is that kind of what you're saying?
100%. So
Yeah.
that's really, really not going to work if that disgust response is highly associated with, say, some kind of sensory sensitivity like visual, smell, even auditory. The other, I'm not going to say disorder, but neurotype probably is a better word, misophonia, which is associated with kind of people chewing, that auditory sensitivity to body noise, maybe in particular over other noises, and the disgust response that gets triggered. So there's these real nuances to that, why that either fear or disgust or other distressing negative emotion, body sensation is triggered. And if we expose people, we're probably going to be lessening their window of tolerance rather than expanding it, which is the aim of exposure, is to expand people's window of tolerance and help them feel safe in the face of, say, that trigger or something else. But that wouldn't really work on a sensory level. That would cause trauma, sensory trauma, and probably cause harm, potentially cause some harm. And it could also do something which really breaks my heart, is cause masking. So people pleasing. So the person does it, they feel a lot of internalized trauma, they mask their way through it, and then treatment's over and they're cured in the kind of medical language. Then they walk away and actually something else shows up, or that all starts again, because what's really been achieved is masking, and not because it's incongruent, the treatment's incongruent with actually what's going on in that person's neurobiological wiring. So I think that's the bit to be really careful of. And it's daunting. How do we really work out what's happening for this person? We may never 100% know, but we can be really compassionate and be willing to kind of let go and think a bit more creatively for these individuals, I think.
Emma, thank you I could talk to you all day about this, and I really feel like there is so much more to say on this subject, isn't there? Thank you so much for coming on, because it's been really, really, I think it's such an important conversation, and all the message to get out there, isn't it?
It really is, Liz, and I think it's, and I know that you see this too, that it's trying to work out what is safe for people and how to help them feel safe in this world and safe in their own identity. So we do have to keep improving how we understand humans and how we understand how we're trying to help them. We can't just keep accepting how it's always been. We have to keep kind of bringing in emerging evidence and understanding and listening to people and what their personal experience is, and be prepared for very individualized treatment. So yeah, thank you for having me and listening to me about my special interests.
No, thank you so much for coming on.
Thanks, Liz.
Thank you for listening to this episode of Hello Therapy. If you found it helpful, don't forget to subscribe, follow, and review. You can get more well-being and mental health tips by joining our email list and visiting the resources section of our website at harleyclinical.co.uk. The Hello Therapy podcast and the information provided by me, Dr. Liz White, is solely intended for information and educational purposes and does not constitute personalised advice. Please do reach out to your GP or a mental health professional if you need support. Until next time, take care of yourselves.